Okay, magandang umaga, Pilipinas. Good morning, good afternoon, and good evening from wherever you are joining around the world. Welcome to today's webinar. We are entering year 3 of this ongoing pandemic, and it is only timely that today we will discuss community health issues through One Health applications. We are streaming to you live through the SEARCA online learning and virtual engagements or SOLVE platform via Zoom and Facebook Live. My name is Jean Labios and I am a program specialist of the Training for Development Unit under the Education and Collective Learning Department of SEARCA, and I will be your moderator this morning. So the short video shown earlier has given you a glimpse about SEARCA and what we do. SEARCA is hosted by the Philippine government in the campus of the University of the Philippines, Los Baños. So we are coming to you live from Los Baños, Laguna, the special science and nature city of the Philippines. So this SOLVE webinar series is SEARCA's immediate response to the emerging impacts of the COVID-19 global pandemic on food security by maximizing the use of information and communication technology platforms to inform, educate, and share evidence-based solutions and tested technologies, as well as best practices on the ground. If you are new to this webinar, this is actually the 39th webinar since it was launched last April 28, 2020. So today we will be joined by experts who will share their insights on our transition from COVID-19 being a pandemic to becoming endemic to our communities. So SEARCA's 11th five-year plan, which was launched in July 2020, identifies EcoHealth, One Health applications to agriculture and rural development as one of the priority areas that would accelerate transformation through agricultural innovation. Before we proceed to our online conversation this morning, please allow me to quickly go over some statistics gathered from the SOLVE webinar held on 26 January 2022. So the infograph shows that 62% of our online viewers were female and the rest were male. It also indicates that more than 70 individuals tuned in via Zoom and almost 200 individuals viewed the webinar through SEARCA's Facebook page. Let me now go over the program flow, which is currently shown on your screen. After my introduction and a few housekeeping rules, we will first have our speaker. We will have our first speaker, Dr. Jomar F. Rabajante, professor at the Institute of Mathematical Sciences and Physics of the University of the Philippines, Los Baños. He is also the Dean of the UPLB Graduate School. So Dr. Rabajante will open our discussion this morning by presenting COVID-19 data trend, projections, and stories based on the epidemic curve. Dr. Rabajante will also present how this new normal will impact, or rather is how it is impacting the Filipino economy and communities. Our second speaker is Dr. Elaine Llarena, Chair of the Department of Science Communication, College of Development Communication, UPLB, and also the leader of the Communication and Knowledge Management Division of the UPLB Program for Zoonotic Diseases. She will be sharing with us some insights on communication and other disciplines in engaging communities to address zoonotic diseases. So I know you are all excited to listen to our speakers, but let me first encourage you to send us your questions about the presentations. So how do you do this? For those of you who are tuned in via SEARCA's Facebook page, you may type your questions in the comments section. Kindly indicate your location now and or country of origin. If you're tuned in via Zoom, please post your questions or comments in the Q&A box, which you would find in the menu bar on your screen. So kindly indicate your location and or country of origin as well. Our SOLVE team will collate, curate, and compile those questions for me, and I will convey them to our speakers. Hopefully, we will be able to cover as many questions as we can in the time remaining. Please be clear when you are posing a question to a specific presenter, or if it is a general question that anybody can respond to. So we will do our best to get as many questions as we can during the open forum. Kindly refrain from posting your email addresses in the comments section. You can provide this information to us upon responding to our evaluation form and e-certificate request. The link will be posted at the end of the webinar. Please note that this webinar will be recorded and will be made available on SEARCA's Facebook page and YouTube channel. Today's presentations will be uploaded on SEARCA's website at www.searca.org. The slides shown during the past webinars have already been posted there. For social media posts, especially on insights or key takeaways from this webinar, please use the hashtag SEARCASolve. And if you are having issues or experiencing technical difficulties with the Zoom online platform, please contact us at solve@searca.org. So kindly note that the views and opinions expressed by our speakers are solely their own and do not necessarily reflect those of SEARCA. So now we can move on to the discussion today. Our first speaker this morning is Dr. Jomar Fajardo Rabajante, Dean of the University of the Philippines, Los Baños, or UPLB Graduate School. He is also a professor and UP scientist at the Institute of Mathematical Sciences and Physics, also at UPLB. Dr. Rabajante obtained in year 2016 his Doctorate of Science degree in Mathematical and Systems Engineering, major in Environment and Energy Systems from Shizuoka University, Japan, as a Japanese government Mombushu scholar. He also got his Master in Science in Applied Mathematics, major in Mathematics in Life and Physical Sciences from the University of the Philippines, Diliman, as a DOST scholar, and his Bachelor of Science in Applied Mathematics, major in Operations Research from the University of the Philippines, Los Baños. He completed a higher education training certificate from the Derek Bock Center for Teaching and Learning in Harvard University and a medical statistics certificate from Stanford University. He was recently awarded as one of the 2021 Outstanding Young Scientists by the National Academy of Science and Technology. He holds an appointment as Junior Associate at the Quantitative Life Sciences Group of the Abdus Salam International Center for Theoretical Physics in Trieste, Italy. I hope I got that right, sir. So his research interest is mathematical modeling and data analytics of complex biological and social systems. Ladies and gentlemen, please welcome Dr. Rabajante.
Hello, thank you very much, Ms. Labios, for that introduction. Good morning, good afternoon, or good evening, wherever you are, because I know there are people watching in Facebook, and also whenever you're going to watch this discussion, because I know probably Circa will record this video and you might watch this later. Hello to those people who are here in Zoom and also watching in Facebook. Okay, so what I'm going to discuss today is mostly about moving forward from this COVID-19 pandemic. As Ms. Labias has said, we might already think that COVID-19 is already endemic. Endemic means this disease is already here and it might stay. But let's see. No, because I think it is too early to say we are in an endemic state, because currently WHO and I think many people still consider COVID-19 as still pandemic, which means that we are still in an outbreak mode. Endemic means that the outbreak has already ended, but COVID-19 is still here. But I think we are not yet at that stage. But it is already nice to consider some of the things so that we can already prepare if ever we're going to enter the endemic state. So I'm here to discuss some of the things that we might consider. And before I go to the next slide, I want to acknowledge that I'm a member of the UP Pandemic Response Team, and there are many things that we have done, and we are not going. We didn't become successful. We didn't become successful because we are just single individuals in the group, but we are actually a team. So most of the things that I'm going to discuss are a result of our team effort. So if we're going to move forward, actually it's kind of ironic, because if we're going to move forward or look forward, we should just present. I should just present with the projections, but actually no. If we want to move forward, we need to look backwards. So what I mean by this is we need to look at the historical trend. Okay, so if we want to check what might be happening in the future, we need to understand the epidemic curve of COVID-19. No? So when we say epidemic curve, it means that most of the things I'm going to say here are based on the things that happened in the past, like in 2020 and 2021. So let's focus first with the global trend. As we see in the slide that I'm showing you, the first part there, the upper figure, is the epidemic curve, which means that the graph here represents the confirmed cases per day. And as you see, it looks like the current wave is like a giant wave, making the other waves, previous waves, very minuscule. Okay, but as we remember, in 2020, these waves here, they are not really that small. Actually, if you're going to remember that time, even around June or even before June 2020, we are already having fears that the waves there are already very high. But as you see, um, by just looking at the figure, it seems like the other waves are not that significant. But actually, no, the previous waves are very significant because many of our experiences regarding this COVID-19 pandemic happened during that time. Remember, we had the long, somehow, quote unquote, in here in the Philippines, the longest lockdowns, and that happened not because of the Omicron, this current high epidemic wave. No, uh, it didn't happen this high wave, but most of our experiences about the lockdowns happened in early 2020 and early 2021. And if we're going to look at this trend, you know, during 2020, if you look at the bottom figure here, it seems like the 2020 deaths, no? So then the 2020 deaths and 2021 deaths, we have very high cases that time of expired cases. But as you see, when we entered the period here of the Omicron wave, the high peak in late December and around early 2022, this late December 2021 and early 2022, when we look at the counterpart figure for the deaths, it seems like the number of deaths is already decoupled uh, from the number of confirmed cases. So we have that kind of trend. So actually, it's very important to note that, because this trend of decoupling the number of deaths from the number of confirmed cases is somehow a good metric, or it's a good indicator that somehow it might be already an indicator that we can really move forward from this pandemic. No, because it seems like the severity of the disease might be, I'm always saying might, because we don't know what really might happen in the future. No, but what's happening is we might be already having the indicator of entering the quote unquote new normal. Okay, and if we can remember also, one of the reasons why we have this kind of pandemic, this kind of outbreak, no, pandemic, which means that many of countries around the world had this kind of outbreak. One of the reasons is mobility. If we can remember, during that time in early 2020, we even had a celebration, a Chinese New Year celebration, and I think that's also one of the reasons why there was a quick spread of the disease to many countries. Okay, so remember this word mobility. Okay, and as you see, this is very also important to note mobility, because even also here in the Philippines locally, most of the cases were sent to many provinces because of mobility of people. Okay, and during 2020 and 2021, if we're going to remember, we addressed many questions, we addressed many issues, we addressed many challenges based on these items here that I enumerated. First is healthcare capacity. We remember that time, especially in 2020 and also in 2021, that we had challenges regarding, number of ICU beds, number of isolation facilities, even the number of our frontliners. So during 2020, actually, the term flattening the curve, was popularized because there is some instance where the number of severe cases is already overwhelming our hospitals. So what we want that time is to flatten the curve so that the number of cases will not go beyond what our healthcare capacity can handle. Okay, so we have that issue in healthcare capacity. And the good thing now, if we're going to look at the news, um, the hospital utilization is already low here in the Philippines. That's good news. It's low because of two things. The number of cases is actually declining, and the other one is the government, our also our hospital associations, they really increased their bed capacity for COVID-19 cases. So yeah, that's very important to note. And also socioeconomic preparations, we had issues. Can we, especially in here in the Philippines, actually also in if we're going to look at many countries around the world, are we prepared to provide, uh, monetary incentives or monetary support in case of lockdowns, like here in the Philippines, the ayuda, and are we prepared to provide optimal care for those isolated, or if we want our workforce to go to the company and not work from home, are we prepared to provide them health packages, paid sick leave, things like that, and also we know that because of the lockdowns, many businesses, not just in the Philippines but actually all over the world, were closed because of there are not much customers to go to the businesses because we are in a lockdown for very long time. And also another one that I think we had challenged before is in terms of COVID-19 knowledge. Remember, during 2020, there were few information. Actually, if you can still remember, in around January 2020, there were still some issues if COVID-19 can, be passed uh, from human to humans or from animals to humans. And actually, that's very nice to discuss later, no? Because we are considering as zoonotic diseases or One Health in this forum. So we even had issues before if COVID-19 can be passed through droplets, or it can already pass uh, through the air. It's already airborne. So there were those kinds of questions. But we know now there are evidences that COVID-19 is airborne. And also we had challenges before regarding in terms of the mutation rate of the virus. And we know that we had many variants in 2021. So as you see, we started with this pandemic with very few information. And the good thing is many scientists all over the world, we really tried our best to study the disease. And now we know there are already many publications on COVID-19. There are already lots of information regarding this disease, not just the short-term effect, but also the long-term in terms of our health. We have the long COVID, or long term in terms of impact to our society. Yeah. And another one is, uh, if we're going to look back in 2020, we had even, we are actually asking questions. Is it, or can our scientific community fast track the creation, the development of antiviral drugs so that our severe cases can be given optimal care? Or in 2020, remember, we even had questions before, can we really fast track the development of vaccines? But as you know, after a year, we had vaccines. And actually, that's a good thing to note that because we have vaccines now, then somehow the the coupling of number of cases, confirmed cases, and the number of deaths, or even the number of severe cases, there's already a decoupling. And I think one of the main reason is the vaccination. Okay, and also that's also actually currently I'm in Italy now, in Europe. And here in Italy, one of the indicators really for places to reopen or to go to the new normal mode is the vaccination coverage of a certain locality, okay, or vaccination coverage of the whole uh, European Union. Okay, but still, even though we have this many information about COVID-19, still, until now, although somehow information can minimize our fear, but still until now, there are lots of uncertainties around. We actually don't know what's going to happen in the future. Uh, are we going to have a waning of immunity? Because if you had COVID-19 before, definitely you have a uh, natural infection acquired immunity. Or if you're vaccinated, then you have a vaccine driven immunity. But we don't know how long this immunity can protect us. I hope it can protect us longer. No, there's also a question: uh, would there be a new variant that might be more transmissible, or can be as transmissible as Omicron, but more severe? We still don't know. And I hope we're not going to have that, because we already have a high vaccination coverage in many parts of the world. But still, remember, there are still many countries with very low coverage. And also in the Philippines, we still have very low coverage in the provinces compared to NCR, low vaccine coverage. So there are lots of uncertainties. But the good thing is, somehow we're not that as uncertain compared to 2020. So one of the things, in order for us to minimize uncertainties, is to know how many cases we have. And actually, one of the things there is testing. Although testing cannot provide us the actual numbers, because I think many people opted not to be tested. They just isolated themselves and their families inside their homes, and not opted not to be tested. Or there's already other alternatives like antigen tests that might not be reported officially. Or there are people who think they just had a flu and then just stayed at home, and you know never got any RT-PCR test. So somehow we cannot have that actual number, but at least by testing cases around, we know the trend. Actually, that's the important, the trend. No, we might not even get the actual number. But as you see, sometimes we think that Europe or USA might have the high number of cases. It might be true, but it also might be because they have lots of testing compared to the other regions. So we don't know. But what the good thing here is, we can know the trend. When is the peak globally of, let's say, Omicron. Actually, we had the peak globally, no? I mean, it means that if we aggregate the number of cases globally, we had a peak last end of January 2022. But even though we had that peak, of Omicron, end of January 2022, still there are lots of cases currently. And currently we are around still 1.5 million cases per day globally. And that number is still high compared to the previous waves. Although we are already at the declining phase because as I've said, we had a peak last end of January 2022. I think we even had one day there, as shown also in the figure, going nearly 4 million cases per day globally. And actually, this is also good to note that if if we are already entering the recovery stage or the new normal globally or even here in the Philippines, it's good that we can still have the monitoring, which is anchored on testing. No, and I hope that the testing labs can still be here to entertain people who wants to be tested, and also I hope that there will be like a self uh, reporting app or website for those who want to take self uh, test antigen kits. But I don't know if that will be accepted. But at least we have that statistics, but I don't know if our Philippine government will have that. Our Philippine government is asking is if you're going to have antigen test and your test turned out to be positive, report that to your LGU. Okay. Now, let's go to the Philippine case briefly before I go to the meat of my talk, which is tips on moving forward. Just to go back to the historical epidemic curve. So this is the epidemic curve of the Philippines. We had the peak here in the Philippines. If I'm going to say peak, actually, most of the cases there are reflecting NCR cases because we had lots of cases in NCR. We had the peak nationally, second week of January 2022. But I said that's because of the NCR. The epidemic waves of the provinces are asynchronous, no? But if we aggregate, we are reflecting the NCR situation because of lots of cases in NCR. But as we can remember, early 2020 and even 2021, we had the CQs in the Philippines, the ECQ, the MECQ, the GCQ, MGCQ. And that happened, the CQs, 2020 up to around September 2021. So that's why we are saying we had the longest lockdowns, I think, globally, the Philippines, because we have the CQs for more than a year, from 2020 up to September 2021. We started the ECQ around March 2020. And then September, we transformed to the granular lockdowns. Because remember, the CQ is like an umbrella, regional or even provincial. Actually, it's actually regional, no, lockdowns imposed to many locations here in the Philippines. But around September 2021 or October, I think, yeah, I think September, we transformed to the granular lockdowns. And I think for the new normal, it's better to have the granular lockdowns than a blanket CQ, because blanket CQ might not be that effective in terms of inhibiting outbreak, and also in terms of socioeconomic impact. So that's what happened is, from the national level CQs, we transformed to the LGU-based lockdowns. And we even had, the T3 initiative, the test, trace, and treat. I think in terms of testing, we are actually good in testing, although for the Omicron wave, we think that the 90,000 testing capacity of the Philippines may not be enough, We from our projections, we even might had around 200 or 300,000 cases per day, new cases per day in the Philippines, but we only recorded around up to 40,000 new cases per day in the during the Omicron wave, which was actually also what we projected. We projected in December 2021 that the peak in the Philippines might happen middle of January with around 40,000 new cases per day. And actually, that happened. We don't want our projections to happen, but it just happened. And our projections is this March, especially at the end of March, we might reach the pre-Omicron levels. Pre-Omicron means, the level before our Christmas holiday last December 2021. And but one of the things that we think we might be somehow not that we didn't have much success is tracing, contact tracing. But tracing the Philippines, it really helped. But I think it's not that optimal because we didn't had good digital contact tracing. There are apps available, but they were not optimized, maximized really, uh, to help our community in inhibiting the cases. But anyway, that's a different talk about evaluating the test, trace, and treat. For the LGUs, I don't know if you're familiar, but for the LGUs, what they follow is the PDITR strategy. So they have this, plan. There are LGUs that really had a good implementation of the PDITR strategies. There are some LGUs that somehow needs improvement, but the meaning of PDITR is prevent, detect, isolation, treat, reintegration. And during the time that the vaccination is already here in the Philippines, we added the plus V, the vaccination in the LGU strategy. So just to provide you some background in the Philippine epidemic wave, during 2020 up to September 2021, most of the interventions we implemented is most of the interventions are mobility restrictions, the CQs and the granular lockdowns. Actually, mostly the CQs that time, mobility restrictions, because remember, as I've said before, one of the sources of the outbreak is mobility. So we had the mobility restrictions. We have the T3, test, trace, isolate. Take note where I put the words. So here, test, trace, isolate is in one line, and then we have the treatment, and then we have the minimum public health standards. But around September, the peak of the Delta wave, we saw a decoupling of the number of cases and mobility, because that time we really reopened our economy. We had lots of mobility, but it seems like the number of cases is not catching up. So there's already a decoupling. And one of the reasons why we had a decoupling of cases that time, that during the after the peak, of the Delta wave, is because of vaccination. We started vaccination March 2021. So as you see, because of vaccination, we had mobility decoupling. And still there's the test, trace, and isolate. Remember here, trace, and trace is used to isolate people. And then there's a treatment for severe cases. And for the general public, we have the minimum public health standards. But around December, during our Christmas holidays, Omicron variant came into the Philippines. Then again, we had the decoupling of mobility, ended, and we had the coupling again of mobility and cases, because there are lots of breakthrough infections, and even those people who had previous COVID-19 infection, or those people who had the vaccines, can still be infected, but less severe. So what happened is, because mobility again came back to the picture, what happened is, instead of having very strict lockdowns, the CQs, what the government uh, is already suggesting you can be mobile, you can open the economy, but always connect the minimum public health standards. So we are already saying that even though we are in alert level 2 or 1, still there should be minimum public health standards. And vaccination is still here, especially to minimize severity of cases. And then remember, before there's test, trace, and isolate. Now it's only isolate. Why? Because if you have COVID-19 now, of course you might not even know you have COVID-19. You might have just mild symptoms. Just isolate. You don't need to be tested or be traced, contact traced. Just isolate. So, and what we are doing now is, if you think you have COVID and you have more than mild symptoms like moderate, severe, or probably, and also very, very much critical, then you need to be tested so you can be given appropriate treatment. So testing now is somehow, especially the RT-PCR testing, is already connected with the treatment. You know, we know there's antigen test that those people with mild symptoms can use, but we don't report much our especially the self test kits. We don't report that much, but the RT-PCR is really connected with the treatment. So you see the evolution of strategies because of of the updates in the science, and also with uh, the mutation of variants. So we adapt our strategies. Anyway, to summarize what I'm saying, if we're going to summarize the interventions that happened during the epidemic uh, curve historically, we can somehow have some lessons. And the main lesson here is we really want to move to the new normal. We want to reopen. But when we move to the new normal, we need to reduce risk. And when I say risk, it's the high exposure, the to minimize vulnerability of our population, especially for having severe cases or even deaths, and to minimize uncertainties. So to give meat on this, the first point is, if we want to move to the new normal, then we need to minimize mobility restrictions. What I mean is, somehow we should not fear going outside. So we need to minimize mobility restrictions so that we can reopen the economy. But we can do this if we can reduce severe cases and deaths. So in terms of data analytics, we need to always monitor hospitalizations, the utilizations of beds, and also I think improvement of our healthcare capacity. So it's actually there. We need to improve our healthcare systems, including financing the insurance system, so that we can really move to the new normal. Without good healthcare system, it's like having some fear that if there will be outbreak again in the future, our health system might not, uh, uh, can still be overwhelmed. So I hope that if we are already here in a state where there's very low COVID-19 cases, still we need to push our government to improve DOH, our healthcare system, our PhilHealth, or our other insurance system, etc. And the third point here is, if we want to move to the new normal, we should not forget monitoring. We still need to monitor cases. The sad thing is, if you see some LGUs or even national agencies forgetting to monitor the situation, then it's kind of sad, because if we want to move to the new normal, we need to monitor, because monitoring reduces uncertainty, and also prepares us in case there will be future outbreaks. So it's also preventive. So our monitoring should be adaptive and sustainable. Why I say adaptive? Because we cannot always, rely always, let's say, on RT-PCR test, because it's very expensive. So we might have a new system, as I've said, for monitoring self-test kits, Or, you know, even if you're not tested, you can monitor yourself by having symptoms monitoring. No, for example, these are like tangible suggestions. If you are in an organization, I have here put here integrating our monitoring in regular activities. So in UPLB we have the OMS where we report our symptoms. Even though we are not tested with RT-PCR, if we have these kinds of symptoms, then UPLB can monitor our health status. So if we are in an organization to put meat, tangible strategies to the 3 points that I've said before, from the previous slide, we need to provide health packages, insurance, paid sick leave to our manpower, especially for those with in casual jobs. They need to have paid sick leave, I hope, and they should have insurance. And yeah, integrate monitoring. And another one, if we want to move forward from pandemic to endemic, we need to promote personal care. Boosting of immunities. We don't know when our immunity will wane, so we need to boost our immunity, and we need to have masking when we are sick, and we need to set up engineering controls, like having well ventilated areas. So to fast track what I'm saying here, because I think I'm already talking too much. This is an example of monitoring in UPLB, the OMS. We can report every day our status, health status, and even record if we had already vaccines or boosters, or if we got RT-PCR or antigen test, we need to report that here. And this is one of the things that we need to look at monitoring is reporting of clusters. So for example, in UPLB, some people reported that they had, they're having flu-like symptoms, and they're in an office. Then UPLB can already detect that clustering. So if we want to move forward, we need to have that cluster surveillance. No, so we know if there will be an outbreak or we are in an endemic, but in endemic might also turn out to be an outbreak later if there are many clusters. Okay, so these are just samples of the things that we still have. The ncov.ph for the dashboards for the reporting of cases and also projections. And if you're in an organization, you need to have monitoring of, if your place is well ventilated, you can have CO2 monitoring, and you can just buy some kits in Lazada. They are very cheap. So CO2 monitoring is recommended to manage COVID-19 spread in schools and offices, especially in new normal. Now, if you're outside the organization, definitely one of the things to add is to monitor community situation. So for example, if you want to go outside, ride a bus or jeep, it's okay not to fear that, because currently we have very low cases. But what I'm saying here is being a risk taker or being a risk averse might change your strategy to put your action anchored with the situation outside. So if the number of cases is very low, then you can go outside. But if the number of cases in your community is very high, then you might take additional precautions. So exposure reduction during high prevalence, that's very important. But if there's low prevalence outside, it's okay to go outside. Just be sure to maintain the minimum public health standards. So to summarize, strategy is proportional to risk. So don't be afraid. Assess the risk outside. And it should be proportional to heterogeneity, which means that our situation, each of us has our own situation, which might not be the same, for the others. There's a person which has a very high exposure because he or she is a frontliner. The other one is not. Then we need to consider that, because our intervention should be somehow personalized. You cannot anymore put like the CQs, which is very blanket, and so our social interaction is heterogeneous. So we need to consider that. Also, super spreading events. Detect where super spreading events can happen. So we can minimize really the number of cases in the future if we know when super spreading events can happen. And that's actually because we don't have that kind of uh, if for example, if you don't have that kind of huge social interaction, then you're safe. But if you think you're highly exposed, then you need to add precautions. And strategy is influenced by the capacity to handle risk. If your office can handle risk, then you can allow people to go to the office. But if you think not, then allow your manpower to still work from home. Or even though you can still handle risk, if you think your manpower can be productive while working from home, then why not? So what I'm saying here is you need to assess the risk outside and how we can handle the risk. So that's the way to move forward. We should not fear, reopening the economy. We should not fear going outside. And yeah, I think I'm going to end here. Yes, and that's actually some of my tips for moving forward from COVID-19. Thank you very much.
Okay, thank you, Dr. Rabajante, for your presentation, for providing more insights and information regarding COVID-19 and what unfolded since 2020 when this whole coronavirus shocked lives and economy. So we also believe in evidence-based strategies here in SEARCA, so that to move forward, we need to understand the past. So thank you for that in-depth recap. I noted what you said, that strategy is proportional to risk and that it is influenced by the capacity to handle risk. I especially note as well the call for beefing up healthcare capacity, something that we can discuss more in depth later because I can see questions coming in right now. So thank you as well for demonstrating what UPLB does. And hopefully this approach is something that other institutions may adapt or even serve as a baseline idea for LGUs and communities to minimize infection rates as we live in this new COVID-19 endemic, maybe. Just to flex. So for everyone who enjoyed Dr. Rabajante's presentation, you may actually follow him on Twitter. His tag is at biomathph. So thank you, Dr. Jomar. So again, may I remind our online attendees watching the webinar via Facebook Live, please start typing your questions in the comments section, including your location or country of origin. If you are tuned in via Zoom, please post your questions in the Q&A box, which you will find in the menu bar on your screen. While waiting for the next presentation to be shared, please allow me to tell you more about our second speaker this morning. We have Dr. Elaine Llarena. She is a full-time assistant professor and current chair of the Department of Science Communication, College of Development Communication, also at the University of the Philippines, Los Baños. She earned her Bachelor of Science in Development Communication in UPLB and later on completed her master's degree MA Communication, major in Communication Research in UP Diliman. She finished her PhD by research degree at Murdoch University in Perth, Western Australia. Prior to joining the academy in 2013, she has vast experiences in project and research management as a national communications specialist, as well as a communication consultant for various international and regional non-government organizations, primarily in animal health and public health relations, as well as other veterinary public health programs in the Philippines and countries in Southeast Asia. As a development communications scholar on science communication and risk communication, her research and public service interests include inter and transdisciplinary collaboration on One Health and Eco Health, WASH or Water, Sanitation and Hygiene, and Biotechnology. Currently, she is part of the UPLB program for zoonotic diseases as leader of the Communication and Knowledge Management Division. Dr. Elaine, the screen is yours, ma'am.
Thank you so much, Jean, for that introduction. So good morning, good afternoon, and good evening to everybody here in Zoom and also listening to us in via Facebook Live of SEARCA. So for this morning, I will be sharing with you One Health in Action. So basically what communication and other disciplines do in engaging communities to address zoonotic diseases. So the One Health concept or approach is not actually new. There are already examples and cases where we can build on and draw learnings from. In fact, One Health is applied in various levels of research, governance, and development programs that holistically addresses the concerns of public health, animal health, and the environment or ecosystems. One of the applications of the One Health approach concerns addressing the emergence and in some cases, the re-emergence of zoonotic infectious diseases. So zoonotic diseases are those of animal origins transmissible to humans or vice versa, meaning the disease can also come from humans that are transferred to animals. Scientific studies revealed that 6 out of 10 new diseases originated from animals. Popular examples of zoonotic diseases are rabies and avian influenza, or particularly highly pathogenic avian influenza, or if you've heard some of the layman terms they use is bird flu. Apart from these two diseases, SARS, which happened in 2003 and 2003 to 2004, was believed to be zoonotic as well. So SARS was experienced in countries in Southeast Asia, including the Philippines. So even the virus that caused the COVID-19 pandemic was said to be zoonotic too. But let us note that there are still studies being done to prove that the COVID-19 virus is indeed zoonotic. So if we relate the occurrence of zoonotic diseases in a global scale, it is considered as one factor that increases risks in relation to health and environment disasters. So other driving factors includes increasing population density because of urbanization that is very present in our society, increased human settlement in high-risk areas such as now people tend to live close to volcano craters or reside in houses or in areas or subdivision or villages where tectonic fault lines are present, which is prone to earthquakes. And even communities, you know, they would settle in coastlines areas where there's a risk of, you know, big tidal waves or tsunami. So another risk or factor that was identified is also the increase in technological risks. So this technological risk causes cyber crimes, you know, and I think I would want to argue that even misinformation, disinformation, we could attribute this also to this increased technological risks. Another is the aging population. So because of modern science, modern medicine, you know, people tend to live longer. So most of the population age, and this threatens the human resource development of our society or if of an area. And of course, as what Dr. Rabajante mentioned, mobility. So increased international travel, which was very apparent, you know, in the early parts of the COVID-19 pandemic. So these factors make also will also somehow makes us realize that indeed we live in a contemporary society faced with uncertainties. And this has been mentioned by Dr. Rabajante a while ago in his presentation. So we can further rationalize all these risks as contributory to the change of our environment landscape and the way we now live. So Dean Jomar did tell us tips now of how we will face the quote-unquote new normal. So some of these changes are brought about by nature, the way in such a way that sometimes we have no control of. But in some cases, or most cases, I should say, they are man-made driven, which can be avoided. So what I wanted to present this morning, or I want to reiterate, is that an application of One Health is also addressing zoonotic diseases. And so I argue that human understanding and interactions can help prevent zoonotic diseases. Now, in the interconnectedness of animal health and public health, it is important to recognize the socio-cultural contexts in communities through the process of communication and community engagement, which I will illustrate in two cases. So the first example of application of One Health in communities is the case of the Barangay Livestock Aid or BALA program in the province of Bohol here in the Philippines. So just for a background about Bohol province, so the province of Bohol is the 10th largest island province in the Philippines. It is in the central part of the Visayas archipelago. So I saw that there are we have attendees here who are from the Visayas and even from Mindanao. So it's about 800 kilometers south of Manila for those who are non-Filipinos, other Asians participants here in our webinar. So according to the Philippine Statistics Authority, Bohol is composed of 47 municipalities and one city, which is Tagbilaran City, and has about 1,113 barangays. And as of May 2020, the current population of Bohol is about 1.4 million. So the Barangay Livestock Aid or BALA program is one of the programs of the Office of the Provincial Veterinarian, which is essential, the BALA program, essential to the coordination of the province office, the provincial office's programs and engagement in the communities. The BALA program mobilized community volunteers as extension workers to support veterinary services in the villages or in the barangays. So the program is a good case of an institutionalized system that integrated the local setting and community values. So, you know, we Asians, specifically as Filipinos, we have the sense of community and communality inherent in our culture. So as Filipinos, we have the sense of, we have these traits of pakikisangkot or getting involved, pakikisalamuha or interacting with, pakikilahok, joining or participating with, and pakikiisa, being one with. These are concepts, I would say communication concepts rooted from our Filipino psychology, or the literature terms it as Psikolohiyang Pilipino. So I believe that the concept of the BALA program was premised on these characteristics, the nature or our willingness to help, to cooperate. I think it's an inherent part of our culture. So to continue background of the BALA program, this was conceived in 1997. So I think more than 2 decades or almost 3 decades. So the aim of the BALA program is to address the growing demand for local resources to provide the poultry and livestock related needs of the communities in Bohol. So barangay or village volunteers were trained and mobilized to provide a sustainable solution to the lack of technical manpower and address the geographical barriers to reach poultry and livestock industry players, especially those who were in marginalized and hard-to-reach villages. So in 2000, the BALA program actually received the Galing Pook Award. So it's a national distinction from the Galing Pook Foundation. It's an organization that recognizes innovative practices of local government units in the Philippines. So in the early years of the program, there were 517 volunteers that covered only 20 of the 47 municipalities. But since its conception in 1997, every decade, the numbers of BALA volunteers have doubled. Now there are about, as of my last chat or conversation with the provincial veterinarian, they now have around 1,310 volunteers, which covers all the 47 municipalities. You will notice that the Tagbilaran City, because in the local government setup of the Philippines, the city is a component city, meaning it is independent. So the provincial veterinary office only covers the municipalities. So now they have this number of volunteers covering the whole, almost all the municipalities in the province of Bohol. So the OPV, or the official of Office of the Provincial Veterinarian, initially spearheaded the formation and coordination of the BALA volunteers that were later endorsed to the municipal agriculture offices throughout the province. So a provincial legislation supported the formation and recruitment of bala in the communities. So the Office of the Provincial Veterinarian of Bohol provided the basic training qualification and other trainings to fulfill their function to be the first responders to animal health needs and emergencies, especially in remote or far-flung villages. With mobile technology, they can easily relay and feedback to the government animal health professionals and veterinarians the field situation in their villages or barangay. So the BALA program, through its volunteers, contributed to improving the monitoring of animal diseases in the province. The program also built a network that was useful at times of disease outbreak and response. So the BALA volunteers were primarily involved in implementing the Bantay Rabies sa Barangay or rabies monitoring in the village as part of the province's rabies prevention and eradication program. So as I've mentioned, one of the concerns of One Health is eradicating rabies, because rabies is a zoonotic disease. The BALA program, what the volunteer does is that they conduct dog population survey and assists in mass dog vaccination in the communities. So the BALA volunteers were primarily involved in the rabies prevention program of the province. And also from this case of this BALA program, we could see that it is an example of how community health, how communities can really work or is already working towards that One Health approach. So another case that I would like to share now in this webinar is the case of about highly pathogenic avian influenza. So HPAI is another zoonotic disease of One Health concern. So again, because the virus is transmissible between humans and animals, but this is particularly with the highly pathogenic avian influenza. So the second case that I will share is about bridging communication gaps on HPAI in Cambodia. So just for a background about Cambodia. So Cambodia is one of the countries in Southeast Asia. It borders Thailand, Vietnam, and Laos PDR. And 20% of the country's land area is used for agriculture. So backyard poultry raising is actually popular in the country. So as of 2020, I've researched that the population of Cambodia, the whole country, unlike Bohol, where it's just one province in the Philippines, the whole country of Cambodia is about 16.72 million. Okay, so in this particular case that I will be sharing, this is the work of Benjamin Hickler. So Benjamin Hickler is a medical anthropologist who conducted an anthropological participatory assessment on communication about HPAI in Cambodia. So the study was conducted in 2007, where I think it's the peak of the outbreaks of HPAI in villages in the country, in Cambodia. So Hickler highlighted in his study the significance of indigenous terms in animal health, particularly in the nominal identification of animal diseases. So Hickler emphasized the importance of working with the local taxonomy or indigenous terms of Cambodian poultry backyard farmers, specifically of poultry diseases. I hope I pronounced this right, Dankorkak or Dankorek in some areas in the country, and Pidash Sai Baksay. Okay, I will discuss further what this indigenous terms mean in their country, as what Hickler probed when he did his field study. So according to Hickler, Dankorkak, which he gathered from the locals, is a generic term for seasonal illness and death in chickens. It is considered natural, impossible to prevent, and difficult to treat. So this is how the local people perceive this local term or a local situation, or what their poultry or their chickens experience in terms of diseases. So Hickler also said that in technical terms, Dan Korkak refers to Newcastle disease. So actually, Newcastle disease is a poultry disease, but is not considered as zoonotic. So because this Dan Korkak have similar symptoms as that of the HPAI, it's sometimes been mistakenly be used to refer to HPAI, which is zoonotic. So given the similarity of its symptoms, so pedash cybaxay is a new term that was introduced in the local HPAI awareness campaigns. So what Hickler was saying, that before HPAI happened in Cambodia, they already used the Dan Korkak. But I think probably in the local communities, to distinguish that Dan Korkak is actually not zoonotic, and they had this new term, pedash cybaxay, to differentiate it as HPAI, in what scientific or English term is referred to as that poultry disease that is actually zoonotic. So with this case, the use of local terms is crucial to crafting the messages for communication campaigns. So in Hickler's research findings, he pointed out that there was confusion about the new term pedash cybaxay and its relationship to Dan Korkak, which became an obstacle to behavior change communication in the country. So during that time, I remember I read anecdotes wherein the local people, the villagers, they were so confused why their chickens die suddenly without them knowing what happened or what could be the reason. So in this case, Hickler recommended actually that there should be distinct management of the meaning of and relationship between the two terms. So this was recommended to provide clearer descriptions or definitions of the new indigenous terms that were being used in reference to emerging disease. So in this particular case of HPAI in Cambodia, it showed that language, specifically indigenous language, is one of the main elements in bridging communication gaps. So from the two examples that I shared, I want to reiterate the importance of recognizing the sociocultural contexts, which includes communication, in addressing zoonotic diseases, as it is crucial, especially in facilitating stakeholders' discussions, recognizing community practices, and understanding indigenous knowledge to better address the prevention and control of zoonotic diseases as a One Health application. So to conclude my presentation, I want to highlight 2 points. One is that inter and transdisciplinarity is inherent in the application of One Health. What I mean by transdisciplinarity is integrating the different disciplines, health sciences, natural sciences, social sciences, that are applied in context of human interactions and beyond the traditional boundaries of the disciplines. And my second point, actually, that I wanted to emphasize is that communication in One Health is both a process and a means for community involvement to reflect on people's ways and recognize their information needs, identify community health patterns, and discuss solutions for actions towards social cultural change. So I'm suggesting some sort of a paradigm shift, that we don't only view communication and the social sciences as a top-down approach. Probably we have to think about how we engage communities, how to identify and appreciate indigenous knowledge, because these are also crucial if we want to face the uncertainties of emerging infectious diseases, that of especially of zoonotic. So I think that concludes my presentation, and I'm looking forward to a good discussion and engagement with our participants. Thank you.
Okay po. So thank you, Dr. Elaine. Especially for extending the discussion from Dr. Jomar's presentation from the trends that happened since 2020, and then stressing the importance of acknowledging the emerging and re-emerging zoonotic infectious diseases, especially the transmissibility between animal and public health, which is what zoonosis is, and how a One Health approach is a good strategy for these threats. And as illustrated by the cases you presented, I especially note your point on taking into context the social cultural environment of communities for effective and efficient communication of One Health applications, which is really, as you mentioned, inter and transdisciplinarity that recognizes communication both as a process and a means for community action. So thank you po for that, Ma'am Elaine. I think we are now ready to proceed with our open forum. So we have several questions lined up, but for our participants, I encourage you to type in your questions either in the comments section of Facebook or here sa Zoom po. Okay, so my first question would be for Sir Jomar first. So, sir, in the trend presented from 2020 to today, cases may have risen, especially since Omicron, but with the relatively lower records of deaths, right? So, can that data help determine that this is a jump point for COVID-19 to transition to being an endemic disease?
Yeah, it's one of the indicators, especially the decoupling of number of cases with severe cases and especially deaths. But it's not that easy to really decide for now if we're already at the endemic stage, because there are still many countries around the world with very high number of cases, which means that we are still in a pandemic. Endemic kasi means low cases. COVID is there, but cases the number of cases very low, but still we are in a pandemic. It's one metric, but it's not enough. Yeah,
Sir,
thank you.
would you say that endemic doesn't necessarily just fall in one country? It has to be like in a regional context to say that endemic na yon and no longer a pandemic. Is that what it is?
Definitely, it really depends, no, how our WHO and other organization will decide on that. But kasi if there are still countries with high number of cases, and especially if, let's say, that country still has a very low vaccine coverage, then there's a huge chance to have of course there's always mutation, but what I mean is there's a huge chance to have a variant that can be the next dominant variant in the future. So we still need to assure that globally we can inhibit the number of cases to be very, very minimal. Yeah.
Okay, thank you, Sir Jomar. Before I proceed to the One Health, Eco Health discussion, Sir Mer, I just have here one medyo focus on the trends na question. Would you say that contact tracing contributed to the improvement of the COVID status, yung pagbaba ng rates? Especially since actually both speakers raised how mobility is a big factor to controlling or the risk infections po. Maybe Dean Jomar could answer, and if Dr. Elaine has an input as well, please do so, ma'am. Yes.
Probably yes, it helped, but I think we weren't able to maximize the technologies around, because I know even there are apps available, but they weren't really used to for even policy making or for contact tracing in your organization. Wala talaga. And even the logbooks, yung mga low tech somehow contact tracing protocols like that, they weren't used to for the actual contact tracing. Actually, what happened is I got COVID last year. What happened is they're just going to ask me, who do you think are the people you had encounters? It's not contact tracing. It's just, it's not the contact tracing that's, very effective. And also contact tracing is very useful during the early stage, if there's still no outbreak, because if there are already many cases, it's really very hard to do contact tracing. So the contact tracing is a function of the timing. If it's already high, it can still be helpful but not that efficient anymore. So to answer that, it might help, kasi especially if for your family, it might help but not maximized.
Yeah,
Thank
Thank
you.
you.
yeah.
Yes, Ma'am Elaine.
So probably, if I may add, but from a different perspective, probably why agreeing to Dr. Rabajante that we weren't able to maximize the potential of contact tracing. Probably I would look at it because our culture probably, or we are not familiar on the importance of what contact tracing is all about. That's why when we fill in logbooks, for example, or things, practices that is part of contact tracing as a helpful tool for during the pandemic, we don't realize it's important, probably because we lack you know integrating it, or at least considering it in the culture that we have, or the practice, or the existing practices that we already have in the country, or even even look at it from a local government level. Because if you compare, for example, Los Baños, right? Well, I believe, or I would say that contact tracing is good in Los Baños because we have the app, right? When we go to the shops, to the restaurants, we have that. But when you go to another municipality, it becomes different. So again, I think the collective way on how we look at things as well. So that's, I think, an issue or a concern that we have to deal also.
Okay, thank you, ma'am. Actually, I wanted to dive right into Nasana to the science stuff. But since we are in the topic of medyo policy and governance, I have here a question for both of you, actually. So were there efforts to communicate or work to communicate these studies that you have with UP, with COVID response teams, UPLB Zoonotic Disease Program, to communicate these projections and studies to government institutions for policymaking, perhaps, or for implementation of protocols and rules for LGUs, ganyan po.
Siguro,
Maybe, yes, sige, sir.
yeah. Definitely we communicate. UP COVID-19 pandemic response team, we have open line with government officials, or probably DOH bosses. So for example, we have a projection, we send them directly our projections. Although it's up to the difficulty here is, of course, I'm also being interviewed in the media, so nakakarating talaga that, but we communicate, pero our job there is just to communicate, to recommend. The policy making itself is with the government people, officials. So sometimes people might think that we are not recommending these things and that, but we were recommending things, but it turns out iba yung yung output. Yeah.
Okay, Dr. Elaine?
Well, in the case of the two cases that I presented, actually, the case study on the BALA program, it's part of my PhD, and I'm actually currently now in communication with the Provincial Veterinary Office, because we are exploring possibility on how to also probe into what are the other things that they are now engaged in terms of the BALA program. And in my initial communication with her, she said that aside from the rabies program, the BALA, they maximize the community engagement or the potential of the BALA volunteers in their disaster and preparedness response, especially because Bohol has been struck with earthquakes and typhoons. So it's I guess the emphasis here really is, recognizing strengths in communities that you can maximize in this One Health approach, in terms of disease surveillance and in terms of responding to disasters. So now they're moving towards not just One Health. Well, I think I would say that it's still part of One Health, because disasters that talks about the environment and climate change, and the BALA volunteers are now tapped for these kinds of responses and activities or engagements in their villages or in their communities. So I think that because there is strong political support, because they have been, well, since 1997, and they've won Galing Pook Award. So I think even if there's a new governor that comes in, BALA program has already been institutionalized. So I think that's the difference with this case, because politically or in terms of policy, it has already been established in the province. And I know that there are these kinds of programs are also present in other provinces in the Philippines, I know. And I'm interested in looking at that as well, because this is something that we can highlight in terms of relating it to the culture or the institutional system that we have in the country. Maybe it could be a solution, if I may say, to address, emerging infectious diseases and any other of One Health concern.
Thank you, Dr. Elaine. So 2 points that I got from both of you. Yung sa side ni Sir Jomar would be, of course, we do communicate this as people from the academics. But yes, thank you, sir, for pointing out that not just because you were able to communicate it would mean that there's going to be policy action about it. However, there are cases like the BALA program where LGUs or local communities are able to do something about it. So I guess it's a matter of national policies versus local policies, and whether yung mga local initiatives natin can actually be scalable. Parang ganyan. So thank you po. Now we dive into the One Health. Oh, yes, sir.
Can I add? Just from experience, with the LGUs, there are LGUs that really cooperate with us and even bring us in their table during their discussions. Like province of Bataan, no, they're really cooperative. So LGU, sa national medyo mahirap, but sa LGU talagang meron. Thank you.
Okay, thank you, Dean Jomar. Okay, so now I have here a question from Nike at Chacoso. Thank you po, Dean Jomar, Rabajante, and Dr. Elaine Llarena. I'm going to get this name correct one day for the very valuable presentation. My question po is for Dr. Llarena. One Health, or the triad for human health, animal health, and environment, is a crucial approach to preventing and preparing for current and future pandemics. However, the environment is the seemingly neglected factor in the One Health approach. So I just wonder what you can recommend in the environmental One Health approach that can prevent COVID or a related pandemic, which actually I have here a question that it's relatively connected there. Can One Health help prevent a new pandemic? Dr. Elaine first, and then maybe Dr. Jomar for inputs as well.
Yeah, I actually agree to that observation that in that triad, environment or the ecosystems, environment health is seen to lag. And there are even literatures that say that wildlife in particular is one of the neglected, how do I say, in terms of studying, in terms of research. But in the UPLB program for zoonotic diseases, we have colleagues there who does studies on bats. Bats are important in the One Health equation, if I may term it that way, because bats in studies says that these are reservoirs, or the new viruses or novel diseases or novel viruses are usually they stay in bats, and it spreads through bats. And we know that bats can be connected with the environment, because if we observe our forests, illegal logging, converting them into residential areas, the bats are now become displaced, or sometimes they tend to stay or inhabit in areas where there are humans. And so that's where the zoonotic, the exchange or the transmissibility or transfer from animals to humans happen, because now bats who usually are up there in the mountains, in the forest, they live there away from the human settlement, now becomes close to us. So in my view, there's the environment factor there. And there are also perceptions. I have read studies who have this misconception about now the bats or the wild animals being culprits for the new for zoonotic diseases. So they tend to have this misconception that, this wildlife should be eliminated so that there will be no spread of disease. But then again, the point is it would imbalance our ecosystem because the wildlife is part of the ecosystem. So I think those things, it still needs to be communicated. I am guilty of that because some of my focus really is more on the animal-human interaction. But yeah, the opportunity to really strengthen in terms of the wildlife or the ecosystem environment part of the triad.
Okay, thank you, Dr. Elaine. Dr. Jomar, would you like to comment, sir?
I think actually even in UPLB we already have people working on planetary health. It's like One Health plus the environment, planetary health, and we even I think had colleagues, Filipino colleagues, who are really working on planetary health. Renzo Ginto is one. But I think in terms of the government, one of the problems is DOH and DNR and the other institutions sort of, they are still separated. I think IATF is one of the good venue for them to talk about this. But IATF EID somehow is being parang must start to have talks pag nandiyan na yung pandemic, if there's already the outbreak, like what happened. So I think there should be probably PCHRD could be one of the venues to have like integration of efforts ng DNR and DOH and the other agencies about this. But there are already some practices. For example, in dengue, we know dengue is highly linked with the environment. But still, for the other diseases, lalo na if there will be spillover because of environmental degradation, I think there's few talks about that. And even for the academics, I know there were some concept papers or editorials in journals, but in terms of research, there are very few researches on planetary health pa. Yeah, thank you.
Thank you, Dean Jomar. So I guess that's another new what do you call that? A new topic for us to explore. I just want to acknowledge some comments in the Zoom chat box. One is from Alexander Morados. From Dr. Elaine, ma'am, we are willing to collaborate for a BALA replication program in Camiguin. Also, about the BALA program, I am very interested to collaborate with you as part of my extension program together with my students. If this is possible, since I do not have the idea if the LGU here in our province is implementing the program already. What should be the requirement, if ever? I am from the University of the Eastern Philippines. This is in Visayas.
Yeah, actually what I would encourage, because the reason why I chose to present this case studies is to inspire actually local governments, because we could see that in Bohol, they could do it and they've been sustaining it since 1997. So probably from Ma'am Tina, we could think of how we can initiate in our community, like try to assess, the indigenous values that we have, because I think in Bohol, it's part of their culture, how they really, I don't know the term malasakit sa kapwa, like they really care about their neighbors, which I think in areas in our country, in the provinces, they do have that culture. So I think it's more of maximizing that. And probably, of course, I noted all this who chatted here. I posted my email, so I could just type here in the chat my email address, so we can have a conversation about potential collaboration and public service activities in your areas.
Okay, thank you po, Ma'am Elaine. Actually, I was just going to say that for our audience who has questions for either Dean Jomar or Dr. Elaine, they are both active in Twitter, and their email addresses, I believe their UP email addresses are available in the online, so you can also reach out to them po via those. avenues. I just want to go back to what Dean Jomar said earlier about collaboration among different agencies. So this is something similar, I guess, to NDRRMC when there was like, dati laging disasters, and now we have a pandemic, and then we have IATF. I just want to relate that maybe as an inspiration or maybe a call to action that we can communicate to, I don't know, governments, like something like what Dr. Elaine has showed us with her case studies, na it's possible in the LGUs, maybe it's replicable and kaya siyang i-scale up po. Okay, so yung next question po natin would be for Dr. Llarena again. In your experience, ma'am, what is the most effective channel or medium for communicating zoonotic diseases in communities? And maybe Dean Jomar might have some inputs for this too, but Dr. Elaine first.
That's the thing. I don't recommend or say that there is a best channel or platform, because what is important, I mean, the platform comes next. I think what is important is to really know first the context or the areas, because in some areas, for example, broadcast or radio is still very, active or very much used. So probably in that area, you can maximize the potential of radio. And although we know nowadays social media is very popular, but I would argue that, social media could also be limiting, because, you can, in terms of the messages that you can put out there, and it could even be, a source of misinformation or misconception. So I could not say that social media is effective. So maybe my answer to that is really to know first the strengths and, what is available in where your stakeholders that you want to communicate information about zoonosis. Know what is, you can, the best, not really the best, but what is popular or popularly used or popularly accessed in the areas. Yeah.
Okay, before I call Dean Jomar, I just want to say, ma'am, that this was actually a similar question was raised in Facebook, actually, from Miss Hannah Grace Akoyong. So, Dean Jomar, do you have inputs on this matter po?
Yeah, I think I'm going to comment not on the communication part, but do we have information to communicate first? That's the first question, because I think even with COVID-19, what happened is we don't have the infrastructure at the start. Remember the COVID Kaya and the dashboards, they were just created at the middle of 2020, not before. So if we're going to communicate about if there will be, emerging zoonotic diseases, the question is, do we have monitoring facilities, especially in the LGUs? No, especially we already have the Mandanas ruling for the LGU. You have, the power, but the thing is, do you have the initiatives to do the monitoring? For example, cluster surveillance, monitoring of, for example, for dengue, of mosquitoes or whatever. Do we have that for your LGU? Because sometimes we depend on the national government. But for the LGU itself, do you have that? If you have, that's good. If you still don't have, then you need to start, because how can we communicate if you don't have the data sets, if you don't have the information? And when I say infrastructure, it doesn't mean na yung sinabi ko kanina, it's only DOH. It should be like integrated with all of the sectors, especially environment, kasi if we have the environment, we need to put there the DNR or other agencies related to that, not just DOH. So yeah, I think that's my comment about that. Yeah.
Thank you, Dean Jomar, for highlighting that. Actually, may isang nag-comment, but it's anonymous. Wala pong group chat ang mga national agency, kaya kami sa LGU ang nahihirapan. Maraming requirements sila na pinapasubmit na data with the same content pero different forms. So that is one problem. Thank you to the anonymous person who raised this point, that it's actually a problem on the ground. Okay, so I have two more questions po. The first one is EcoHealth, One Health related. In the Philippines, there are many backyard piggeries, and pigs are common sources of I hope I get this right, tiniasis or tinea solium or pork tapeworm. Tiniasis is part of the neglected tropical diseases or NTDs. Do we have relevant studies on this in the country, and what have been the recommendations so far? Maybe Dr. Elaine first, and if Dean Jomar has inputs, then please feel free. Yes, well.
Sorry, but I think I'm not in the position. I'm not so much familiar with that type of disease. But I think I know that I have colleagues in the UPLB zoonotic, the UPLB program for zoonotic diseases who are looking also into the neglected tropical diseases. So probably also, if it's okay that I can also sort of promote the program. We have a Facebook page and Twitter, and if you have other concerns on zoonotic diseases, we have colleagues who are from multiple different disciplines. I think Sir Jomar also is part of the program. So that I think you can ask our colleagues from the program. Yeah.
Yes, Dean Jomar.
I'm not really familiar if there are people working on that with that disease, but within my circle, for pigs, for swine, what I know, there are groups, of course, ASFS is there, and the other one is working with porcine epidemic diarrhea, PED. But I don't know if there are people working on that kind of disease. For neglected tropical disease, I'm part of a project on schistosomiasis in Mindanao. So, but that's within my circle. I don't know if there are other groups working on different types of NTDs. Yeah.
Okay, thank you, Dean Jomar. Okay, so one last question, which I think is medyo everyone is very curious to know about this, and we'd like to know your inputs as experts. So with regards to mobility restrictions, and now here in the Philippines, it's alert level 1. What do you suggest for institutions in planning to implement 100% physical reporting very soon? So do you think 100% physical reporting at offices or other institutions or buildings, banks, or people in the service industry can still be considered as mandatory in the new normal when the work from home setup actually worked for 2 years already? Comments po?
Yes.
Yes, Dean.
100% manpower, it's feasible. Although the word mandatory, I don't know if that's a good word, kasi there are people who really want to stay at home and do work from home because they're more productive with that. I'm not sure with the 100% mandatory, but 100% without the word mandatory, it's feasible as long as remember what I've showed you, the tips. If you have those tips on healthy organization, like you have the insurance, the packages, the health packages. That's one. The other one, of course, vaccination. That's another indicator there. And the third one is remember, if you are in a room without good ventilation, then you need to consider to have a good ventilation there, or at least have a CO2 monitoring on the CO2 monitoring. And I think the other one also, yung monitoring of symptoms. And I think that's good to have monitoring of symptoms with or without COVID, even in the future. Because even flu, if, for example, you have someone there who entered the room with coughs or colds or flus, something like that, and that person will go to the office. It's not really, like, for me, good to go to the office, because you might transfer the flu virus to the person, and that person might bring that to their home. So somehow, with or without COVID, we need to have that kind of symptoms monitoring in the office, especially to have the cluster surveillance. So if you have those kinds of um, protocols in the office, you can probably have the 100% workforce. But I don't like the word mandatory. Yeah, thank you.
Thank you, Dean Jomar. I have online with us our SEARCA director, Dr. Glenn B. Gregorio. Sir Glenn, is it okay if I ask Dr. Elaine to give a comment first before you raise your question, sir?
Sure.
Okay, Dr. Elaine, your comment, please.
Thank you. Just adding to what Dr. Rabajante, Dean Jomar said, I think also with this, we have to face the reality that we now live in this uncertain world. And part of that realization is being empowered, like just like what Dr. Rabajante said, like if you know you're not feeling well, even if it's 100% or if it's mandatory, but if you are empowered and you know that you should and you care about your colleagues, your office mates, your family, you know what to do. And we have been bombarded with messages and things that we have to do if we don't feel well, diba? Another is even the basic concept of washing hands. I mean, those are very practical and day-to-day things that we can do, and something that we has to be instilled in us, yung parang like when we are driving, diba? It's just it's an tacit skill or tacit knowledge. So I think now that we have to realize the uncertainties, that there are uncertainties, and science communication plays an important role in that aspect. Part of which is that we have to really, we are faced with the challenge of increasing science literacy. And I think we all have a part to do that, to increase science literacy or science appreciation for that matter in even in our communities. And even, that's why it's very important that we engage them. Yeah.
Okay, thank you, Dr. Elaine. And our SEARCA director, Dr. Glenn Gregorio. Yes, sir.
Yeah, thank you, Jomar. Thank you, Elaine, for that very timely presentation, and cause us all the more to be encouraged to be expectant that we will be having a sustained alert level 1. This question is just a general quick question on what happened with this BIP, the Virology Institute of the Philippines, which everyone's excited to have, but it been stuck somewhere. Is this still be happening, or what's your comment about this? And quick comment. Virology Institute of the Philippines.
Yeah, actually, I don't know, Dr. Glenn, the current status, but because I'm currently part of the governing board of the National Research Council of the Philippines. During there were meetings with the VIP, especially to bring, our scientists to be included there, because NRCP somehow like a group pushing that scientists from the different institutions be involved with VIP. But the actual creation of VIP, I don't know what's the status, but there were talks to involve the scientists. May idea ka ba, Dr. Elaine, about the status of VIP?
Din baka mas may...
There are also I read some articles. There were already like balik scientists, Dr. Glenn, na I don't know if they're already here. I think the Black Tat scientists will be directly involved with VIP.
Yeah. Actually, I just want the update, because what they're saying in the Congress, in the Senate, they are talking about it, but it was they are saying that it's already being done from the different institute. If you get all these virologists from the different institute, then many of these institute will be reduced into a smallest institute, because they have a big virology department in this different institute. So they are just supporting the research in biology and virology, but they don't want to have it, or they want more data to show that it's more efficient to have a new institute where you'll be pulling out those scientists and put them in Clark, which is more complicated, or it may dampen a little bit the research, because you have to relocate scientists going there to Clark. Thank you.
Thank you, Dr. Glenn. Dr. Jomar or Dr. Elaine, may response pa po kayo?
Wala na naman. But I think, Dr. Glenn, it's good to really have the VIP, because currently researches, of course, there are researches being done at the universities, no? But I think one of the institutions really working on the research is RITM. But I think the manpower of RITM is not enough. And also, RITM is also working on other diseases, not just the viruses. So I think it's good to have that Virology Institute, especially kung especially if there will be also a branch, I don't know, in the future about having our own group creating the vaccines. I don't know, but I think it's one good step for the future. If there will be future pandemics, I hope wala na, but if ever there will be future pandemics, it's a good step. Thank you po.
Okay. Thank you, Dean Jomar, and thank you, Sir Glenn, for raising that very important question. So that sums up our open forum. Thank you, Dr. Rabajante and Dr. Llarena, for that very insightful discussion on One Health strategies as we move forward in living in this new normal with the coronavirus. So as mentioned, if you want to tap our speakers, please do head over to the UPLB Zoonosis program that has a Facebook page. Tama po ba, Ma'am Elaine? Yes, and actually both Drs. Elaine and Dr. Jomar are searchable in Google as well. So before we close this webinar, may I request our speakers for some closing or takeaway message po? Maybe Dr. Elaine first and then Dr. Jomar.
Yeah, I always advocate for inter and transdisciplinary approaches in dealing with One Health. And I think it is very evident that, you know, we really have to learn. It's not just a concept, but we can be innovative in looking at the applications of this inter and transdisciplinarity. And I think one of which is looking at, even in the communities, engaging them. I always also advocate for recognizing indigenous knowledge, indigenous ways and practices. So I think that's where I'm coming from. So and another is that, you know, we really have to accept the reality of uncertainty and anticipate and have that, you know, foresight, even in how we conduct our everyday lives. So I think that's the way to go. So thank you, Jean. Thank you for inviting me here in this webinar.
Okay, thank you, Dr. Elaine. Dean Jomar?
Yeah. Many people advocate stability, but actually I don't like stability. What I advocate is moving forward to be better, evolution to be better. And I think this pandemic is a good start for us to evolve, to be better, especially for our health system. We should not forget the lessons learned, na kahit painful yung mga lessons natin in this pandemic. You should not forget them because we can use these tools to have good infrastructure, good policies, good even organizations, institutions for the future to handle future pandemics. We should not go backwards. We should not be going back to 2019. No, we should move forward to 2023, 2024, etc. So yeah, that's my final talk. Thank you very much po.
Okay, thank you, Dean Jomar. So thank you to both our speakers. On behalf of SEARCA, led by our director, Dr. Glenn Gregorio, we would like to express our sincere gratitude to Dr. Rabajante and Dr. Llarena for taking the time to join us today. It has been a pleasure to have both of you with us this morning, and that ends our webinar. But before we close, please let us know what you think about this session by following the link to a quick feedback form shown on your screen. The same link will direct you to the request form for the e-certificate, and your feedback will help us improve our online learning events. Please note that we will only accommodate requests for e-certificates within 24 hours after the end of this webinar. Kindly wait for your e-certificate to be issued at least within a month, as we receive a lot of requests for e-certificates. So thank you for your understanding and patience. So please join us again for our next online conversation on March 30 at 10 o'clock in the morning. In celebration of Women's Month, we will feature women leaders in the field of agribusiness for increased income productivity. Please don't miss it. So let us help one another get through this COVID-19 pandemic, especially with our lessons today. Thank you, Dr. Elaine. Thank you, Dean Jomar. We hope that as we go along, we will be able to create a community of better, bigger, and smarter farmers and farming communities. Once again, this is Jean Labios for SEARCA. Have a good day, stay healthy, stay safe, and goodbye, everyone.